So, okay. Thanks everyone. So today I'm going to be talking about a specific global health inequalities in global health in relations to migration. I will be focusing on migration and HIV because a recent systematic review of 38 studies globally, half of these are studies based in Europe, have found that HIV prevalence ratio is higher among migrants than in native-born populations. And then because most of these studies are based in Western countries, one of the findings is that many of the people who live with HIV in these studies are people who come from African backgrounds, who are asylum seekers and refugees, and also particularly pregnant women as well. And so because of this pattern, often there is a racial stereotype that migrants are disease carriers, meaning that they got the HIV in their home countries, then they move to the host countries, and then they even like spread the HIV in the host countries. So that racial stereotypes still exist in media. The way they've reported about HIV issues among migrant communities are still kind of carrying that discourse. But in reality, in kind of maybe about in the last 10 years, epidemiological studies have shown that actually there's a significant amount of these HIV acquisitions happen after people migrated. And so we knew that across 11 European countries, about 30% is essentially a post-migration HIV acquisitions. And even in places like Australia, where generally the HIV epidemiology or the prevalence rate is quite low, among the lowest in the world, there is a shift towards the migrant communities. And then among these migrant communities, we also know that about 33% of HIV acquisitions happen post-migration compared to 25% pre-migration. So then the question is, what contributes to vulnerability to HIV among migrants after they migrated? If we understand vulnerability as social, economic, and cultural drivers that pattern HIV transmission, often, we kind of think about the relationship of the social, economic, and cultural drivers to sexual and drug-using networks. Particularly, we're kind of thinking that, when it comes to HIV, it's obviously transmitted sexually and through drugs. But then there are complex social practices that exist within these networks. And the complexity is because these networks, again, are patterned by that social, economic, and cultural relations with actors and agency that exists in public and private sectors and in communities as well across host and home countries. And so we need to go beyond than just focusing on immediately the sexual and drug using networks. We need to kind of see migrants' relationship in a more complex way and looking at different types of relationship. So one concept that we can borrow from migration studies is called migrant networks. So sociologist Douglas Massey defined migrant networks as a set of interpersonal ties that links migrants, former migrants, and non-migrants in origin and destination areas through the bonds of kinship, friendship, and or shared community origin. So this original definition is essentially developed in the context of trying to understand what drives migration. Why does migration occurs? And then trying to understand the determinants that contribute to migration, we then know that one of the tendency is that once a group of people successfully, quote unquote, migrate to a new place, then they can share idea, information, money to the communities back in their home countries that will then contribute to the formation of ideas that migration could be a solution to whatever problem that people have back home. And so this relationship between networks and aspirations are quite important. There can also be reciprocal, as I will talk about in this presentation. And it's also important to talk about that resources, that information, idea, and even financial resources, because the ways in which resources are distributed are through these networks, and the distribution may also be shaped by wider inequalities based on gender, sexuality, class, ethnicity, etc., etc. And so in this study, we're focusing on gay migrants, the migrant networks of gay migrants, because many gay migrants from non-Western countries, they also have quite a complex sort of set of relationship. First of all, because many gay migrants from non-Western countries, they're showing a very much an eagerness to form relationship with the local gay communities in the host countries, while at the same time still navigating relationship with their diaspora communities. A systematic review found that gay migrants in Western countries, particularly North America, they're prone to develop high rates of unprotected sex, alcohol, and drug use that then increase their HIV vulnerability. And then focusing on gay migrants in France, for an example, those who are newly arrived and originated from North Africa and Asia have been found to more likely to engage in unsafe sexual practices due to a wider sort of migration-related determinants, such as visa status, access to health coverage, employment, and financial well-being. And so it is very timely to kind of try to understand how migrant networks of gay migrants then influence their post-migration HIV vulnerability. In here, I'm focusing on newly arrived gay migrants because the systematic review have been found that newly arrived groups are the most vulnerable to HIV. But also in Australian context, we know that newly arrived gay men from Asian countries, in particular Southeast and Northeast Asia, there have been experiencing an increase in HIV diagnosis or new HIV diagnosis compared to Australian-born gay men. And so there's a kind of like a very much starts inequities that affect this group. But what is so interesting and why migrant networks then become really important concept for us to test, quote unquote, test and understand is because with newly arrived Asian-born gay men, we have identified that their risk behaviors are actually quite low in terms of HIV risks, but they're highly vulnerable to acquire HIV. So is that a contradiction? We don't understand this we haven't quite understand this quite well. But what we do know is that among this group, they tend to have fewer sexual partners compared to Australian-born gay men. They tend to report condom use. And then for those who engage in high-risk sexual practices, like they engage in orgies, etc., etc., they access HIV tests regularly. And then there's also high awareness and preference towards pre-exposure prophylaxis, which is a type of biomedical prevention whereby people who are at high risk of getting HIV, they can take daily pill or to prevent HIV. So this means this sort of findings come from obviously behavioral science. And this is where I think to try to understand why is it that a group that has a low HIV risk profile is still kind of very highly vulnerable to HIV, we need the help of social sciences. And migrant networks, with its root coming from sociology of migration, can be very useful to develop that sociocultural and relational understanding of social and sexual practices. So in a sense, this is kind of contributions from social sciences as well. So again, the aim for today's presentation is to examine the usefulness of migrant networks to understand post-migration HIV vulnerability. This has come from my PhD studies in which I study sexual health literacy among newly arrived Asian-born gay migrants in Queensland. Just a little bit about my positionality. In the beginning of my PhD study, I used to be grouped as an insider researcher because I come from Indonesia and I identified as gay at that time. And so therefore, this is an insider research. And then sometimes with this kind of imposition as an insider researcher, there's a lot of like misconception. For an example, I don't understand a lot of other Asian cultures, even though we have similarities and all that sort of things. That there are still things that I don't understand. So in a lot of sense, I actually also an outsider. So the insider-outsider thing becomes kind of like a moot point because it's not really helping me to understand the participants. I also need to mention that by the time that I started my PhD study, I already had about 4 years of experience working as a peer support workers, mostly supporting migrants living with HIV. I also have experienced racism within Australian HIV care, which I share in a recent paper that got published in the journal Health. So for those who want to capture that QR code for the paper, you can do that as well. So, what sort of methodological framework that I use to study migrant networks? Well, first, I look at the tendency of public health researchers in studying migrants and identified that actually a lot of these studies tend to be ethnocentric, meaning that ethnicity is the central point of difference. It's often being seen as the risk factor or what contributes to, poor behaviors, poor health-related behaviors and knowledge. But as we identified before, in the case of newly arrived Asian-born gay men, the behavioral science actually shown they actually have a low risk HIV profile. And then ethnicity as well, if we become too focused only on ethnicity, then ethnicity often becomes like a stereotype and therefore becomes a proxy to race. So I use the colonial framework because I want to delink from this kind of tendency in producing knowledge that in the end, just reproducing common assumption and racial stereotypes. And I think this is kind of aligned with the approach that's needed to study migrant networks, because both the colonial and migrant networks require the researcher to be intersectional in their thinking, to examine marginalization, belonging, and resources that people use to maintain their health and well-being. So I did 33 interviews with 11 participants. You can see the socio-demographic on the slide here. I just need to mention that what I did in terms of the methodologies, that I did a repeat interviews. So it wasn't just like a single kind of one and done type of interviews. Actually, I did 3 rounds of semi-structured in-depth interviews in which the interval is between round 1 and round 2. There was about 3 months difference, 3 months gap between round 1 and round 2. That was very helpful to get me just to kind of understand people's explicit understanding of HIV, sexual health, their own kind of migration journey and aspirations. And then between round 2 and round 3, there was a gap in like 2 or 3 weeks. So it wasn't kind of like longitudinal, but it was a repeat interviews. What kind of themes that come up? The first one I mentioned before, that is really important in studying migrant networks, to look at people migration aspiration. And essentially, most participants demonstrated that the kind of underlying reason or motivation for them to move from Asia to Australia is to move away from the idea of conservative Asia and assimilate into progressive Australia. Conservativeness and progressiveness is often based on career work conditions that participants had experienced in their home countries and in Australia, and also the desire to live as out and proud gay men. However, we also found in the conversation that there is a lot of like other factors that shapes that perception of conservativeness and progressiveness, such as colonial history, cultural products, the kind of like music, movie, books that people read, and also educational institution and curriculum in Asian countries that often portray that, Western countries are progressive countries. And that kind of like produce this kind of colonial mentality. So we can understand this from Joseph here.
It's something that I discovered here in Australia, but then again, it was ingrained, I think, in my mentality. Because you know how my home country has been colonized by 3 different countries. So I guess back in my home country, if you see someone who is a foreigner, or if you see someone who's Caucasian, you would feel that they are superior, and so to hang out with them or to be associated with them would make you feel like you are part of the group as well.
Yeah. So what's the impact of having an assimilationist aspirations to migrate? Essentially, then people's view of the world kind of shape into 2 things, that the world is shaped into progressive countries and backwards countries. And so the social practices that the participant use to form their migrant networks are also can be understood into 2 types of category. The first one is selective practices, which is a type of social practice to keep a distance from the idea of the conservative Asia due to internalized fear of homophobia, socioeconomic competition, and labor exploitation. So you can see here the migrant networks of Joseph. So you can see that Joseph is being put in the central of this pie chart. And then you see boxes and you see circles. The boxes mean that Joseph met those actors the first time before he migrated to Australia. After migrated to Australia. The circle is the people that he met before he migrated. And so this is a very typical view across all the participants, which is people actually keep mentioning people that they've met after they migrated as the important people in their life and in their migration journey, meaning that that desire to assimilate is quite strong. And so if you look at family and Asian diaspora here, there are actors like sister. This is the person that Joseph came out to, and the sister actually accepted his sexuality. And then also the Asian diaspora, you see friend 1 and 2. Also, that's like a group of people who accepted his sexuality. So there is this kind of contradiction in which the participants use selective practices to stay away from fear of homophobia, to stay away from potentiality of homophobia, but through selective practices itself, they were able to find people that they can trust, who accepted their sexuality as well. So essentially, they couldn't generalize and stereotype people who come from their home countries, but that is the reason why they enacted the selective practices as well. Now, what is also interesting is that you see an overlap between Asian diaspora and local gay networks. There is the box called Friend 324. What it means is that what happened, Joseph met a couple of gay friends through his diaspora kind of community. So there is also an overlap as well, which then also contributed to the idea that, this conservative Asia is also a perception and also kind of like an internalized fear. And then the other side of selective practices is embedding practices, which is a type of social practice to assimilate into Australian society. And the focal point to assimilate is essentially through local gay networks, which is dominated by white gay men. So the case here is Brian, who really tried really hard to have a group of local gay friends. And he tried 2 different avenues through his university and other kind of group, and he found it difficult to actually form friendship. And then he and other participants often mention racism as part of like the challenges, although those racism often were so subtle that participants were telling those stories of racism with a question mark. Was that really racism or was that not? Because it could be quite difficult to identify. However, they do lots of things to try to kind of form relationship. By relationship, I mean friendship and dating with local gay men. They were able to identify that a lot of local gay men often talk about, going into sexual health clinic or use PrEP, which I mentioned before. And so they also do those things because they kind of see it as a cultural practices or sexual health practices that local gay men do. And therefore, it becomes more enticing and appealing for them to do that as well. So the other reasons of why migrants engage with sexual health services is not only for health-related purposes. For some, it's actually because of the kind of culturally appealing factors that makes them then drawn into doing healthy behaviors or practices. And then also engagement with local gay networks kind of influence their kind of workplace relationship, meaning that they were looking for a workplace and in which the working environment accepts their sexuality. But there is a downside to try to focus on a lot on white gay men, because about 4 participants reported drug use for the first time in their life in Australia, despite knowing that they could actually access the same type of drugs in their home countries, and they didn't access harm reduction programs, as kind of reported by Hamza.
All of my drug experience begin in Australia. Back home, I don't have access to. Maybe I'm not aware of it, but also it was normatively bad. But here it is part of embracing all my identity.
So what we can understand from that is that whiteness is a cultural capital. So what do I mean by that? If we go back into the impacts that selective practices and embedding practices bring for post-migration HIV vulnerability, we could understand that selective practices often they only bring a very limited type of support and resources for the participants. So I'm mentioning here that family and Asian diaspora provide emotional support during times of crisis, including when one is exposed to HIV and sexually transmitted infection. So emotional support could be in the form of like going through tests, sexual health tests, HIV tests, while calling or chatting with sister in the case of Joseph, so that he had someone to talk to, that he can just like be himself and then get that kind of like emotional support. Obviously, this type of support is important, but they have limited relevancy as a cultural capital to prevent HIV, because a lot of these actors back home don't really understand about the sexual culture of gay men or sexual health knowledge for gay men too. And so the embedding practice actually was being seen as more important because the everyday relationship with white gay men that contributed to cultural capital in the form of embodied desire to access sexual health services and PrEP among the participants. So why am I naming the cultural capital as whiteness? Because when I look at the way in which participants talk about Australia, Australians, and also white people, often you kind of see that there is a dominancy of whiteness in their conversation too. So the key takeaways: qualitative examination of migrant networks is effective to provide a meso-level view of sociocultural drivers of HIV post-migration. It gives people agency, meaning that, I'm trying to focus on how people see their social life, who are the people that they perceive as important, why they perceive those relationships as important, and in what way that influence their post-migration HIV vulnerability. At the same time, those relationships are structured through structural factors such as race, gender, and sexuality. Second, queer migration is not merely a sexual migration, meaning that it's not just a migration driven by sexuality. Sexuality actually intersects with socioeconomic conditions and race. Now, coming back to the dilemma that I was talking about in the beginning, why do newly arrived Asian-born gay men have low-risk behavioral profile but highly vulnerable to HIV? So we can understand that the low-risk behavioral profile actually comes because a lot of the newly arrived Asian-born gay migrants put a lot of efforts to assimilate. And that includes kind of like trying to understand what is the sexual health culture in Australia, and it's highly biomedicalized, and therefore PrEP was being seen as kind of like an important symbol if you want to be seen as part of the local gay community's members. Some of the participants at the same time, they used drug for the first time in Australia through white gay men with no access to harm reduction education either. So this also puts them into risk or being vulnerable to HIV. So whiteness in this sense could be seen as a double-edged sword. It can bring people some positive and negative when the orientation is to assimilate. So the subgroup that could be most vulnerable to HIV are those who use drugs for sex with limited knowledge of harm reduction, and those who cannot afford PrEP or maintain other safe sex strategies. I just want to mention that in talking about racism and sexual health, I've faced a lot of challenges. This is not an easy kind of topic to discuss. A lot of people are resistant against it. There is a tendency, as the literature kind of talk about in Australia, in Britain, and also in Western Europe, to silence discussion about race. So racism in itself can be a challenge to talk about racism and sexual health, which I have written in a paper that I published about, I think, 2 years ago. So that's it.